Good morning, everyone. So I'd love to invite all the panel to come on stage, please. And today we're going to start evolving the discussion. And what we're going to be focusing about is the hybrid consultation. And when you think about hybrid consultation, you think about this magic combination of digital, back to physical, and back to digital. Like the whole journey and pathway of the patient. And today I have a couple of interesting people, and you can read up their names over there. And I just want to kick off straight into the conversation, all right? And maybe we start with Anuj. So Anuj, like, when we think about hybrid care, all right, the first thing that comes to mind is, having a call, telemedicine, and having a discussion, and then having with a call to action. In your role as CEO and founder of 𝐂𝐞𝐝, how have you seen this evolve, especially in the past few years, as with the impact of COVID and other things? What's your journey?
Yeah, thank you for that question. So I think the first evolution of telehealth was essentially point-to-point, right? So provider individually to patient. Right. And it was usually for something that wasn't particularly chronic or high acuity. But then what I think of like a hybrid consultative approach is delivering care for patients who often most need it. So high acuity or in a specialty that's not covered in their geographic area, right? So when you look at emerging markets or you look at rural or even in the United States, rural parts of the country often lack specialty care. And that's where a hybrid consultative approach comes into play. It's effective for triage, so it can sift through and figure out who is the highest acuity and actually route them to in-person care. And then it's effective for delivering care over a wider geographic area, which is a big part of what our company does. So yeah, I think there's an inherent degree of complexity, which we can, I'm sure, talk about. But for me, when I think about this, it's about delivering care to a larger population.
Wow, so we're already starting having some keywords here, like population, looking beyond, just the simple one-to-one consultation, point-to-point. Very interesting points. And I'd like to move to Fran A. And Fran, in your role as president of Reach Healthcare, what are your thoughts on hybrid consultation? Have you seen it work, possibly? Do you have some story to share with us there?
Yes, we've seen a significant number of examples of where it has worked, and much of that success has come out of the research that has been conducted that studies hybrid models, and in particular in addressing areas where we do have underrepresented or underserved populations as a result of the lack of specialization. That's where we've found the greatest amount of value.
Wow, models of care. I like that keyword. And just before the panel, we had a lovely conversation with Prof. Miller, who is an e-health expert at the World Health Organization. And we were talking about reinventing, refreshing our care models. We were talking about benefits. Any further thoughts on that?
Yeah, so I've been involved in telemedicine probably since around 2007.
Wow, quite some time.
Yeah, we had a big program in England to put medical records, electronic medical records across the NHS in England and various other projects. And one of the large projects we had was an early pioneering trial of telemedicine. Okay. It was called the Whole System Demonstrator. And the results of that, it's only a 4-page document that's still on the internet.
The Whole System Demonstrator?
The Whole System Demonstrator.
All right.
Now, the technology then was very basic, but we could see potentially there were some very, very significant benefits.
All right.
And we knew that, as many other countries in the world, that over time our population was aging and that there was a shortage of clinicians and allied professionals, nursing staff. And we needed to find more cost-effective and efficient ways of delivering high-quality healthcare at an affordable price to people, because demand was going to increase in a non-linear and exponential fashion. We see that with diabetes, for example. So I've forgotten the question.
No, like, I really wanted you to elaborate, especially on the benefits, the benefits of this hybrid. How can it take us to the next decade, or how it will help us improve patient outcomes?
Yeah, well, I think one of the things is the model of healthcare is changing globally. So we're seeing around the world a move away from the fortress-like structure of acute facilities, primary healthcare, mental healthcare, social care, into a more patient-centric system. With what I've already mentioned, the shortage of clinicians and allied professionals, we need to be able to deliver, say, healthcare more effectively. And telemedicine, I think, was helped by COVID, that it became more acceptable. We can deliver huge benefits. One of the exercises I've undertaken was to have a Markov model built of the potential benefits. So if we look, for example, in the area of chronic conditions, which is, the World Health Organization says, the largest area of expenditure in healthcare worldwide, and it's growing very rapidly. So if we look at IDF, for example, the International Diabetes Federation, they say diabetes is going to increase by 2045 worldwide by 46%.
Wow, that's quite a staggering.
Yeah, so the Middle East, for example, is reckoned to go up by 96%, Africa by 143%. All that's available on the internet. So how can we address those problems? How can we deliver healthcare? And I think, because it's not just about classical medicine interaction, it's about lifestyle changing, diet, exercise, mental well-being, and we're seeing developments in the area of mental well-being as well as in the development of wearable devices. Because one of the problems you have is if you ask a patient with a chronic condition that they're going to have for the rest of their life, please take some measurements every day, they'll do it for a short period of time. But after a while, they'll stop doing it. And we need that data to be able to measure them.
Yeah, in fact, you're reminding me a bit about this graph about intensity and consistency. So intensity, when you have like these big jumps, you know, like this big effort, and then slowly and steadily it goes down, but it doesn't help you arrive to point B.
Right. And I think the other thing is that traditionally we've always seen, perhaps somewhat arrogantly, the West as being the leaders in this development.
Okay, tell us more.
One of the things, I was invited to speak in China. I'd never been before, a couple of years ago. And I was amazed at the developments that are taking place in that whole area of telemedicine. In one area, they're using the technology they've developed for their astronauts, the tachonauts they call them, and they're now through their sort of WhatsApp, WeChat, through WeDoctor, rolling that out to 1.4 billion of their population. So, and they're being able to assist, you know, countries like the Philippines, for example, with 5G technology and low-cost handsets. And they're winning many friends and getting sort of real benefit on the geopolitical sense. And I think sometimes in the West, maybe we should follow and at least be active. Sorry to go on, but
that's okay. That's okay. You know, we definitely have a lot to learn from each other. But
sorry.
One thing that really struck me about Jonathan, who I'd love to hear from, is that you're focused on comprehensive wound care services. That really struck me because in my experience, working in primary healthcare, working in a hospital, working in all these different places, now I'm focused more on public health. But working in all these places, I know how wound care is so important. And this topic has resonated a couple of times in this conference. You know, we had a panel just yesterday, and it was about ulcers, amputation, and how important wound care comes now. So, John, tell me about your journey as a founder surgeon of comprehensive wound care services.
No problem. So, you know, wound care just in general throughout the international world is expensive, and with comorbidities and issues, there's issues with lifestyle changes as well. So I think the number one aspect as far as wound care is concerned is how can we, number one, treat the patient, how can we decrease costs, and how can we increase resources, specifically wound care dressings, specifically a multifactorial approach to treating the patient. So from a hybrid standpoint, we're looking at two things. Number one, cost effectiveness. Number two, access. But I think where we can go in the future is increasing patient compliance by increasing the patient experience. And I think if we can figure out how to, from a tech standpoint, make the telemedicine consultation and the experience more formidable for the patient, we're in the right direction.
Well, but I'd love to hear more a bit, Jonathan, about how does the hybrid consultation come into the picture in your place? And are you encouraging digital? What's your approach there?
Correct. So from a wound care standpoint, our subspecialty, like my colleague from a rheumatology standpoint, we can do a lot of visual consultations in healthcare. We can literally look at the wound and say that looks infected or it needs some type of immediate management. So from a telemedicine and hybrid approach, we can educate our patients, number one, and make sure they understand what to do and how to treat the wound effectively. So looking at the patient and having the ability to treat the wound from a visual standpoint is one of the advantages from a hybrid telemedicine-based approach.
Yeah, so our audience definitely loves stories. So I'm going to start with you, Anuj. Has there been like a moment in your work where it has struck you so much, that like has driven you even further into this mission of your company and your work? Like some specific moment where you say, "Wow, we really had an impact there."
Yeah, no. So again, I come from the United States, and when you think of the United States, of course, very expensive. Not very efficient healthcare, but it is the United States. Theoretically, you can get care whenever you need it.
Okay.
And when we started digging into developing the concept for our company, we spoke to hundreds of patients with autoimmune conditions. These are conditions like rheumatoid arthritis, inflammatory bowel disease, and many others. And actually, it came across one patient in particular that I remember very vividly. Predominantly autoimmune conditions affect predominantly women. In the case of conditions like lupus, women of color, and that healthcare delivery, especially in the United States, is unequally distributed. So this patient was a single mother, and she had gone 10 years without being diagnosed with rheumatoid arthritis.
10?
And it effectively had caused irreversible joint damage. And she's a single mother and now unable to essentially manage her children effectively because she was ping-ponged through the care system, going to a primary care physician, not being adequately diagnosed. They didn't recognize the conditions. She lives in a very rural area of the United States. Single working mother, so she can't take off time to drive, the 2.5 hours to a major city. And so the tools are right here in front of us, right? We've been here at this conference for 2 days. This doesn't require like a high degree of compute. It requires essentially a virtual care service to essentially, diagnose this patient remotely. And, progress happens slowly and then all at once. And I think over the last 2 years with the COVID-19 pandemic, we recognize that actually, wow, a lot of care, especially in specialty needs, can be actually delivered virtually, right? And you can actually implement a much more effective model of triage to essentially filter out, okay, who are my high acuity patients that I immediately need to figure out a path towards treating them urgently versus how can I monitor, a wide panel of patients that geographically don't have a specialist in that area. So that patient, that story really obviously compelled us to start this company, but that was just one particular salient example.
Wow, 10 years.
10 years. The average, just in the United States, the average length of time is 4.5 years to be diagnosed.
Specifically for rheumatoid arthritis, you're talking
Specifically for autoimmune disease.
For autoimmune. Wow, that's...
Just to schedule an appointment takes on average 74 days. So there's a high degree of barriers to accessing care.
I think we really have to continue working and advocating to ensure that, these waiting times as much as possible and whatever we can do with our available resources as much as possible. And now we have technology, not now we had technology, and let's make sure that technology plays a role in, making sure that the patient outcomes, the positive ones, are reached early. But Fran, did you have any eureka moments, such as Anuj, with some experience?
Yeah, I think there's quite a few of them, right?
Okay.
I mean, if I were to go back, I think one of the things that we learned from the research that we conducted during COVID was that there are a lot of specializations that aren't leveraging digital technology.
Right.
And in women's health, that's a prime example of where there's a significant amount of work that can be done. And so the question becomes, why? Why is that? First and foremost, it's around, particularly in some markets that are private pay markets, the challenges around reimbursements. And even though you see specialists who are wanting to adopt the technology, if they're not receiving the reimbursements at a level that they think that is comparable to what they should be receiving as compensation, they're not as inclined to adopt the technology. The second one is, while we have a tendency to push the issues of digital literacy on the consumer, the reality is that it's not the consumer, not even the older adult consumer, that's the challenge. The challenge is, in fact, the low digital literacy of clinicians themselves. And so there's a huge gap and opportunity there as well. And thirdly, it's a really misunderstanding and an opportunity to learn how to better integrate the technology into the clinical workflow, and recognizing that there are various roles that are necessary in order to be successful. My colleague on stage here had referred to lifestyle medicine as an area, and we have seen multiple examples of where lifestyle medicine and where we've seen the use of personal generated data as being very helpful in not only introducing the technology, but for making for compliance and persistency amongst patient populations. But the challenge is that as a system, regardless of what system type you're in globally, none of those systems embrace personally generated data. So that creates even more complexity on what it is that we're doing. I love the example on wound care. We noted in Royal's NHS as an example, where the use of the technology for management of wound care was extremely successful because it was able to limit the amount of time that individuals, particularly individuals with limited mobility, had to go out to have their wounds monitored on a weekly basis. And that was huge. But we also have to remember that why we're talking about hybrid models is because a hybrid model is a hybrid model. It's not necessarily intended to completely superimpose or replace the role of human-to-human interaction. For many older adults, it is the only interaction that they get with the outside world when they get up and they are able to get out. And so we need to sort of make for a balance between those two. One of the programs that we have been doing since 2016 is with older adult population. Our oldest participant in our virtual senior care program with self-help community services was 89 years old when she first received her computer. Ooh. And continued to use it up until the age of 101. Our oldest patient in our chronic yoga, online yoga classes for chronic disease management is 94 years of age. So we know the opportunity is there even with those who aren't so-called natives of the technology. But this notion of integrating it as a component of the clinical workflow necessitates clinicians being willing to be receptive of guidance that they're receiving from suppliers like those that we are seeing here on stage.
Wow, those quite some numbers there. Like like today is like the day of the numbers here, and I just love those ages. Like, well done, honestly, on making the. And like let's think about it. That was like 89 101, right? Yes. Wow, like honestly. So let's honestly not underestimate, the digital literacy and the determination of a number of our people, and let's work harder to make sure that we reach out and make sure that they're ready for this journey as well. Prof. Miller, some thoughts? Maybe you have some wonderful stories from your journeys and travel.
Yeah, I think one of the elements that we're missing in all of this is an integrated care record.
Okay.
I was very interested to listen to your Deputy Prime Minister, Health Minister, and the initiative in Europe on the data space, because we need to be able to use our data more effectively. And the problem across the world, and I've worked around the world, is that often data is siloed. Even, you know, we think it's okay in the West, but right across Europe, United States, for example, Australia, New Zealand, doesn't matter where you go, it's the same problem. And we lack standards that enable us to be able to semantically interoperate that data. So yes, we have SNOMED-CT, yes, we have ICD-11. But if we look at naming conventions for lab tests, units of measure, reference ranges, for example, naming conventions for diagnostic imaging, dictionaries of medicines and devices, you know, we have them in England, for example, but it's not been universally implemented consistently, so we can't use that data. Now, one of the problems with telemedicine, in my experience, because it's really Wright brothers at the moment, is that the traditional acronym for a patient-clinician interaction is SOAP. Subjective, objective, analysis, and plan. Yes, I can do the subjective bit. It hurts here, doctor, but only when I laugh. But when we get to the objective part, the clinician is less able to measure vital signs that they may wish to do. So the development of low-cost and multi-parameter measuring wearable devices, I think, are really, really important in that development. And then I think the benefits are truly huge. I had some work done by a charity in the UK called the King's Fund, which does quite valuable research. And we looked at a model of telemedicine that has all the elements we would want in it. And I said, what would be the potential saving? And it was of the order of 30% in cost terms. And largely, that was due to reduction in the chronic condition area of advanced developments such as stroke, cardiovascular disease, and amputations. So if you can minimize the probability of those occurring, you do two things. You reduce the cost substantially, but you improve the lifestyle or the quality of life of the patient. So the gains are there, but I hope very soon, sorry to go on, but I hope very soon you will be part of that, and you've got a great opportunity here in Malta to be an exemplar in Europe, to demonstrate the benefit of having an integrated healthcare system and the data that can flow and not be siloed. Sorry, sir.
Yeah, agreed, and I'm going to try my 1,000% to make that happen, definitely. So, John, your eureka moments.
So since we're talking about numbers, let's look at some numbers in the US as far as the cost of wound care. 50 billion every single year goes to treating wounds. If you break that down based on the type of wounds, pressure ulcers 10 billion, venous vascular 12, diabetic close to 14 billion every year, right? So the eureka moment is when you're consulting the patient that's in a rural setting and can't get to a provider, or you're consulting a group that's in an urban setting and they don't have the resources to get to the provider. So from a provider standpoint, again, it's cost reduction, it's accessing care to patients, but more importantly, you want to connect with your patient from an experience standpoint. And I think all my colleagues on the stage understand, as we've been discussing, the more that you interact with your patient, the more you can bring them into, quote unquote, your healthcare home, where you can consult them, help them on their daily lives, and reassure them that their clinical issue will improve if you continue to work together as a team. So I think that's the number one thing you got to focus on.
Wow, so we're running a bit out of time, but one thing that I'd like to kind of bring together from all that has been told today is that we're looking at having better value for the money spent on healthcare. I think that's like definitely one key takeaway that I can take on all of this. But to achieve that, we need to ensure data persistence across all different systems, whatever system you use, but we need to make sure that the data is actually there. So if you need to take action, you need to make sure that you have the right information at the right context and at the right time. And just quickly, maybe like we don't really have that much time, but maybe a 10-second, like or one key takeaway or one keyword from all of you guys. Just one keyword that you want us to focus on. Just one. Give it. We have 30 seconds. Go for it.
I'll say that to do this well is difficult, right? I think just to give credit to my colleagues here, they mentioned reimbursement, they mentioned integrated data, and I'll add a third one, which is compute. Like all of that information, even if it is integrated, requires a high degree of coordination. So Sorry.
Okay.
that's not-
Compute, coordinate. Fran.
Integrated multidisciplinary care teams.
Okay. Prof. Miller.
Internationally agreed clinical vocabularies, not just ICD-11 or SNOMED CT, but right across the board, and not to be given its optional use, but it needs to be regulated so we can maximise the use of our data and deliver excellent healthcare, and it's one of the projects I'm working on.
John.
Improve access by improving patient experience.
Wonderful. And thank you for our audience for listening to us, and a big clap to our panel. Thanks. And we move on. Thank you.